Well, good morning, and can I welcome everyone to this, the 20th meeting of the Public Audit Committee in 2025. This morning we've got apologies from Jamie Green and Stuart McMillan, but I'm very pleased to welcome Stephanie Callaghan, who is substituting for Stuart McMillan and who is attending the committee remotely this morning. Agenda item 1 for the committee is to consider whether or not to take agenda items 3, 4 and 5 this morning in private. Are we all agreed? Agreed. We are agreed. Thank you very much. And the second item on our agenda is further consideration of the Audit Scotland report into general practice progress since the 2018 General Medical Services contract. And I'm very pleased to welcome our witnesses this morning in this first session. We're joined by Dr. Ian Morrison, who is the chair of the Scottish General Practice Committee of BMA Scotland. Good morning, Dr. Morrison. Alongside Dr. Morrison is Dr. Chris Provan, who's the chair of the Royal College of General Practitioners Scotland. Good morning, Dr. Provan. And we are joined remotely by the Vice Chair of the Royal College of General Practitioners Scotland, Dr. Chris Williams. Dr. Williams, good morning to you. And can I say, if you want to come in at any point, if you indicate in the chat box, and we will endeavour to bring you in to answer any of the questions which the committee has got. We do have quite a number of questions to put this morning, but before we get to those, I would like to invite both of the representatives in the room to give us a short opening statement, and I'm going to begin by inviting Dr. Morrison.
Many thanks, and thanks to the committee for the invite today. The 2018 contract was presented to the profession in 2017. GPs were promised to be the conductor of an orchestra comprised of multiple team members delivering 5 key areas to reduce our clinical workload and release us to provide the role of the expert medical generalist in the community. Of the 5 key areas, only one has moved out of GP in its entirety, and that is vaccination services. However, this has cost the taxpayer significantly more than when delivered by general practice. Vaccination rates are lower, and we're in the process of moving it back to GPs in Highland due to significant pressures in the remote and rural setting. The other 4 areas, community treatment and care services, or CTACs, this is largely nursing and healthcare assistance providing wound care, blood tests, data collection, etc. Pharmacotherapy, urgent care, and additional professional roles, primarily mental health workers, link workers and physios, have all struggled to have a demonstrable impact across the nation to reduce the current GP workload and allow for more proactive care in the community. Even when, in December 2020, there was an instruction to health and social care partnerships to focus their efforts on the development of pharmacotherapy and CTACs, we have seen little progress towards either being an autonomous service delivering all the descriptions within the 2018 contract. In addition to not delivering these services, we have also seen other elements, such as premises and IT development, not progress at a satisfactory pace, with practice premises an ongoing risk to practice sustainability. The contract was also supposed to be followed by Phase 2, which was to allow for the direct reimbursement of practice expenses to bring a level of stability to the current model. However, this has not been possible to progress, and we're actively looking at alternative mechanisms to support the profession. The reasons for the failures of 2018 are multiple, and we welcome the Audit Scotland report for highlighting many of them. The fact that the contract provided anything but GP time is being felt acutely across the system, and the years of inflationary erosion and neglect within budgetary decision-making means general practice is at crisis point. With record levels of demand, we face the ridiculous paradox. We see GP underemployment occurring at an exponential rate. The solution is direct investment into the most efficient and fiscally disciplined element of the NHS. Then we can look to secure a better future for general practice and the people we serve across Scotland. Thank you.
Thank you very much indeed. I'm now going to go straight to Dr Provan to give his opening statement. Dr Provan.
Thank you very much, Committee, for this opportunity to give evidence. We welcomed the Audit Scotland report and its recommendations. It painted a stark picture of general practice on the front line and was no surprise to GPs in the front line. It shows there's a pressing need to really reprioritise general practice within the Scottish Government's healthcare strategy, because general practice feels as if it's in a state of perpetual crisis, with a shrinking general practice workforce, rising demand because of the complexity of patients seen in an ageing population, as you know. Really a mismatch between what we're expected to deliver and the resources available to us to deliver that, leading to the potential for moral harm to general practice staff who are trying to do their best. We feel that the infrastructure, our premises, our IT is not fit for purpose. But as Chair of the Royal College of General Practitioners, I want to really champion the value of the general practice to patients and to the wider system. Our recent report, Whole Person Medical Care, the Value of the General Practitioner, I'd recommend to you. It brings together some evidence around this and how healthcare systems which are strong in the community and primary care are more effective. But we need consistent, long-term, sustainable investment in general practice. As we've heard, several commitments in the 2018 GP contract have not been implemented, and there's uncertainty around the medium term and funding at the moment, which is creating difficulty for practices employing staff and GPs. Recent research has shown that the lack of perceived workload change since 2018, this is leading to GPs reducing their hours or even leaving general practice just to cope with the burnout of the intensity of the job. There's a lack of data that hinders our ability to assess the 2018 contract and its impact on patient care. That lack of data in the situation has really obscured the activity, the strain on general practice, and really the cultural and systematic neglect of general practice, where our budget has gone from 11% down to 6.5%. The contract, as we've heard, is the remit of Dr. E. Morrison here. I'm not going to go into any more specifics around that. But I sincerely hope this inquiry, our discussions, mark a turning point, because I believe there's a growing political will and consensus that we need to see meaningful investment and focus on primary care to improve the care of patients. Thank you.
Thank you very much indeed. And you've covered many of the topics which we will pick up this morning, from IT to premises to funding to the delivery of support and services. Can I begin with something a bit more political and practical, perhaps, and that is going back to the Programme for Government statement by the First Minister, where he spoke there about the delivery of an extra 100,000 appointments in GP surgeries. What was your reaction to that? I'll begin with you, Dr. Morrison.
Well, we did make a reaction known to the public at the time. General practice provides 650,000 appointments per week. So 100,000 is less than a working day. Now, the 100,000 that was identified by the First Minister was not for routine general practice. It was specifically for cardiovascular disease prevention. And we have been instructed to actually look to draw in people who don't use services to try and identify hidden risk in the community. So they are very separate from coping with day-to-day demand. But we do welcome the cardiovascular disease enhanced service, and we do see it as a demonstration of general practice's role in the preventative agenda. But if we are to move towards dealing with the capacity issues within general practice, then we need much more substantial investment than what was proposed.
Okay. Can I just, you mentioned investment there, and can I just check with you on some of the figures which are being used? Because again, if I look at the Audit Scotland report, it talks in paragraph 28, I think Exhibit 4, about the funding situation. And it basically says, if I can characterise it in this way, that between 2017-18 and 2023-24, direct spending on GPs by the Scottish Government was up 33% in cash terms. And they describe that as a 7% real terms increase. They then go on to talk about a real terms reduction of 6% between 21-22 and 23-24. But that's the kind of overall impression which is created in the Audit Scotland report, which is before us. But when I look, Dr Morrison, at the letter that you sent to the committee and some of the things that you've said already this morning, you're talking about a shortfall in funding of 22.8%. You're talking about, I think the expression you've used in communications with the committee is that the funding practices received for every patient has been eroded year after year against inflation since 2008. So how do you reconcile the conclusion drawn by Audit Scotland with what you've been saying?
So I think the Audit Scotland figures are maybe year on year, whereas we're looking at the entirety of the last 17 years. So we have seen hyperinflation have a significant impact on GP practice cost pressures, and we have also seen multiple pay awards into the contract not keep pace with inflation over the years. So we can share with committee our workings over how we've come up with those figures. Very welcome to do that. But we are absolutely clear that we have seen a significant erosion. And that's before we talk about our share of the NHS budget. Now, this NHS budget has naturally risen because healthcare costs have gone up. Yet our share of that budget has been significantly impacted, now likely to be below 6% this year, when historically in 2008 it was 11%. So the workload has gone up, but our share of the resource has fallen year upon year.
Okay, and I think other members of the committee might return to some of these points as well. Can I move on to another aspect of the report, and something which I asked the Auditor General about when he was before us a few weeks ago, and that is we are talking in the end about a whole system here, and the difficulties faced in secondary care within the National Health Service is pretty well documented. Extensive waiting times, a large number of people on those waiting time lists. Could you describe for us, and maybe Dr Provan can answer this as well, what the impact on general practitioners has been of that persistent and almost intractable increase in waiting times, people who wait in treatment in hospitals and so on? Maybe bring in, well, you choose between yourselves who wants to answer that first.
Well, Ian's microphone's on, so you're starting now.
Okay, so yes, the waiting times for definitive interventions means that patients repeatedly come back into general practice with worsening of their existing condition. So we are seeing people with, more analgesic requirements, more alternative therapies until such time as the definitive treatment is delivered. whilst that takes place, their level of general frailty tends to increase. That means that when the definitive intervention takes place, it is more likely to suffer complication, and their general frailty level is unlikely to return to their previous baseline. So all of that leads to a wider impact on overall general practice usage, because we are dealing with more frailty in the community that could have been prevented. So, yeah, it's a very complex picture.
Yeah, I mean, I would just echo, it's really workload that patients are repeatedly coming back for further treatment with their general practitioners, which problems that should have been actually sorted out in secondary care because of long waiting lists. And that's very difficult for the patients and their level of suffering because of that, and also GPs who can't. It's difficult to help people in that situation. I mean, we've seen the erosion of general practice as a shield to protect secondary care, and because of that, secondary care potentially is busier because more is leaking through, and we need to actually shift that focus and funding to build that up again in the certainly medium term, to allow us to actually work in different ways and more in the community. But we need actually the infrastructure to be able to do that. And the evidence shows that we can do that.
Okay. I think Dr. Williams wants to come in on this question as well. Chris Williams, over to you.
Thank you, yes. So it's just to explain that there is a new data set that we collect that can help provide some insight into the busyness of general practice. And so Public Health Scotland published this data now under the working title of the in-hours activity. So previously we would look at appointment data. We would look at the number of appointments, and when we, especially through COVID, there was a lot of analysis around about whether it was face-to-face appointments or remote consulting. We can see the data that there are roughly the same amount of consultations going on, but there's a workload that's increasing in the background, what we might call indirect activity. So lots of looking at results, lots of reports, lots of updating to specialists when a patient is being referred and comes back and wants to tell us that things are getting worse, and wants the team that hasn't yet seen them to be updated, that the patients don't have a direct mechanism to do that. So that some of that activity is visible through that data set. Thanks.
Okay, thank you. And again, we will return to some of these themes during the course of this morning. Can I ask a final question just about placing the observations that are in the Audit Scotland report with how this affects things on the front line? So multidisciplinary teams were very much a theme in the 2018 contract and were part of the new era that was being heralded at that time. But again, when I read the Audit Scotland report, which is under discussion at the committee this morning, they are quite scathing in that they say the expansion of multidisciplinary teams has been slower than planned, deadlines have not been met, and there have been implementation gaps. Again, could you describe what that looks like on the front line of the provision of GP services across Scotland? And I'll begin with Dr. Provan this time.
Yes, I think unfortunately the introduction of the multidisciplinary team has not freed up GPs to be the expert medical generalists that was hoped. The research shows that there hasn't been that freeing of workload as expected. I think we have many different skills in the practices, but in rural areas they've not been able to recruit them. There's not been adequate funding in certain areas to actually make a difference. 2 hours of a pharmacist's time for a limited period in the practice doesn't necessarily allow them to make a big enough difference to actually help free up GP time necessarily. It's been differently implemented in different areas, with different spending in different areas, with a different view of what is actually needed to be delivered as an MDT. There's estimates that it would cost another 125 million to fully implement vaccine pharmacy and CTAC. So it really hasn't, unfortunately, created enough headspace for GPs to see the complex patients, which is what we want them to do. There's also been delays in premises loans, as you're aware, and all of these create uncertainty, difficulty around funding, difficulty to employ people. But there hasn't really been the impact on the ground that we would have hoped.
Okay, thanks. I think, again, Dr. Williams wants to come in briefly, perhaps, because I need to move on to Mr. Beattie's questions. But Chris Williams, again, over to you.
Yeah, so I suppose just to point out that when MDT arrangements came in, we didn't have the IT licensing arrangements that matched that. So you would have workers of all sorts of different types that were spread across multiple practices, and that in its own generated additional costs. But I wanted to highlight that services such as first contact physiotherapy, it's a fabulous new service, but it's bringing work into the general practice environment rather than freeing up GPs to be the expert medical generalist. And it's also to highlight that within the Audit Scotland report, that our patients don't understand a lot of these rules or how to access these rules. And it's difficult for our patients to navigate this new system, even when the information is displayed prominently on practice web pages, and receptionists are trained to describe this to our patients.
Thanks, that's really helpful. And again, I'm sure that's going to be picked up by other members of the committee. But I'm going to now invite Colin Beattie to put some questions to you. Colin.
Thank you, Convener. I should probably, at the beginning, declare an interest in that I have met Dr. Morrison previously in his capacity as a senior partner of a medical centre in my constituency. Information. Something that we've talked about at many different iterations in front of this committee. Publicly available information for the government is extremely poor quality generally across the NHS, and it's been difficult to pull it together. The information on GPs is basically not very good either. And the impact of incomplete data, poor quality data, on decision-making and the use of public funds has frequently been discussed at this committee. If you don't know the outcomes of what you're spending your money on, you don't know if you're putting the money in the right place. What role do you think GPs should play in providing that information and supporting improved data collection? Let me start with Dr. Morrison.
I think we have a key role in terms of population health and management. So the problem is that, for good data input, you require robust IT systems that make it intuitive to have, non-variable, highly collectible, impactful data, whereas our IT systems are exceedingly poor quality. If I'm being blunt, we're running on Internet Explorer 8 software, 2004 servers. We have multiple systems trying to speak to legacy systems, so it's very hard for the IT system to have a robust data capture that can be reliable and easily interpretable. So, we have to focus on the data input capture before we then look at the greater analysis potential. But there is huge potential there, and we are very, very open to work with government on how we can make that more transparent, because we are absolutely keen to demonstrate the value and just the incredible workload that's currently taking place.
You touched on the Scottish Government there. What do you think the Scottish Government and NH boards need to provide in the way of support across the board in order to improve the data collection?
Chris Williams may pick me up here because he's a bit more of an IT expert, but if you compare ourselves to England, England have a secure cloud called the Spine, which all systems can feed into. Scotland doesn't have that infrastructure, so all our systems have to independently speak to each other, which makes the collation of data existing within each system harder to centralise and therefore interpret robustly. So having some sort of central repository or spine would be hugely advantageous, and it would actually open up the potential of a lot more IT interventions to help assist workload and patient flow.
Dr. Williams, you've been had the finger pointed at you as an IT expert in this. Do you have any input?
Yeah, very happy to contribute and to back up Ian Morrison's description of the incredible potential that is there in terms of we now have the ability to extract data from GP clinical systems in a way that we didn't have before. We have a joint controller information sharing agreement that is now in operation between boards and between practices. And we also have practices provided with data protection officer support as well. So there is some infrastructure in place. I would draw attention to the GP quality clusters as a structure that should be able to do good quality improvement exercises on the data to ensure that people are entering the right things, that they're findable in the right places. But our GP quality cluster work is very underpowered, so that there is some list support that the local intelligence team, but that had really not been properly in place over COVID, because our data support, our analysts got diverted to a lot of COVID-related activity. But I think that the GP quality cluster arrangements, if they were properly powered, if there was adequate resource going in there, all the types of data support and the time needed for GPs to do this non-clinical work, that would hugely improve the situation.
Dr. Provan, one thing which I'm become aware of is the fact that we push the pharmacists as being a backup really in primary care, and they issue prescriptions, and yet I'm told that doesn't actually interface with the GP practice, and so anything could be happening in the pharmacy, but there's no record of it.
Yeah, I mean, pharmacists have a great contribution to make to the team. General practitioners hold risk and see patients and do a different kind of role. But the IT, again, is not fit for purpose. People talk about AI and other activities, which is really, really important. But GPs just want a computer that works when they switch it on in the morning, that communicates with other systems. Seriously. And we need to go back to really getting core services that work for patients moving forward. We want to have electronic prescribings where the GP can just send it electronically to the pharmacist, and that is crucial. That's top again of lists and surveys of what GPs want. It would save so much staff time and GP time to be able to do that. And this has been really promised or asked for more than 10 years. So that would be a priority moving forward. to have that communication electronically moving forward would definitely be a priority.
Thank you. I'll move on to something a little bit different. We've talked about, in general, about people having difficulty in accessing healthcare, and the Auditor General's report highlights that people are finding it more difficult to access healthcare through the general practice. What do you? Here's an easy question for you. What do you think is the reasons for that? And do you have a view on what steps the Scottish Government has taken so far to help address that? And maybe I'll come back to Dr. Morrison there.
Thank you. So, fundamentally, we have a higher number of people per GP. We have a higher number of people with disease. We have more disease prevalence in the community. We are caring for one of the most unhealthy nations in the Western world. And we have more treatment options than ever before. So, you know, all of that leads to exponential growth in our workload. Now, the only mechanism by which that can be addressed is to have more capacity within the system. And because of the increasing complexity, comorbidity that we're dealing with, we need to have more generalists within the system in order to have a much more holistic, patient-centred approach to how we manage this. That type of consultation also requires more time. So we are incredibly time short because our capacity is really, really stretched at the moment. And I can, as much as the MDT were there to try and help release some of that capacity, whatever capacity it's introduced has not kept pace with the exponential growth in that demand.
And Dr. Provan, what do you think, what's your view on the steps that the Scottish Government have taken so far to address the issues?
We've been working on the recruitment and retention 20-point plan because we need more GPs, and we support that plan because GPs are leaving because of the workload and burnout. However, fundamentally, we need more GPs, and that means investment in practices to be able to employ those GPs. We have the situation in Lothian where training numbers of GPs have gone up, but we don't have resources in the system to employ those GPs and practices to provide services for patients. Yes, there is good work going on to support people like me towards the end of their careers to keep going, and mid-career, and support them. But fundamentally, we need a shift in how we resource the number of GPs and the number of GPs per patient. The report says we're not going to hit the 800 target. The number of GPs has actually reduced by 4.2% since 2015 in whole-time equivalents. So we need that basic investment in practices, and things won't change until that arrives in practices and they can employ GPs, and then GPs actually hold risk in the system, as I said already, and we actually are very busy supervising many of the other members of the MDT. That's been one of the consequences. We spend a lot of time training and supporting our team. So we need more of those to do all the roles that GPs can do effectively.
I'm going to come back to MDTs, but you mentioned about WTE, and I'm just wondering what sort of proportion of doctors are now working part-time?
The proportion is going up. The recent research shows that because of the workload, GPs are coping by reducing the amount of patient-facing hours just to be able to cope with that. I also want to ban the term personally part-time GP, because the evidence shows that being a so-called part-time GP is a full-time job with all the hidden workload behind that. But we need to have more full-time equivalents to be able to really provide appointments for patients. But Dr. Morrison may know more as well about this.
Dr. Williams, do you have anything you want to add to that?
I might just explain that I suppose the Audit Scotland picked up on people's experience of access. I mentioned earlier that the many tasks that occur in general practice, the many contacts that aren't face-to-face consultations. So that there's lots of encounters that people have with general practice where something is done, something is performed, a prescription is provided, a fit note perhaps, where people don't feel that they've had a consultation with their GP in the traditional sense. So some of the difficulties we have to face is how we describe the increased efforts and that activity, and at the same time that the experience of our services is reducing.
Thank you. My final question is about MDTs. They were seen as a huge opportunity to improve the situation in GP surgeries, but as has been touched on, the Auditor General refers in his report to the 2023 survey by Public Health Scotland, which found that in some cases MDTs have created more work and increased the GP's workload. Now, partly because of more time supervising, more time training. It just seems to, I'd like to understand what else is involved in this. There's obviously different strands in this. Do you have a view on this, and what steps have been taken to improve the situation? I'll maybe ask Dr. Provan to...
We have many groups, physiotherapists, pharmacists, who have not worked within primary care before and need to learn the intensity of the job, the number of patients you need to see. They're used to a different work rate and culture where you're not managing complicated things with the risk involved in that. It's usually a section of one area that they're looking at, and that takes time to adjust and train. If you come to my practice, often I will have 3 or 4 people waiting outside my door to ask me what to do about something, which is fine. But I'm risk managing that in the sense of, with the experience and the broad knowledge that GPs have, we can say, well, we need to do something about that now, or we even need to send that person to hospital or refer them. Most of the people we take care of ourselves. So it's that kind of role which was never really taken into account when the contract was first introduced. And there's a lot of work around supporting care navigators and training around that. And the MDT have brought more skills to the practice, but have actually created some more work as well as alleviating some work.
But isn't that short-term pain for long-term gain?
To some extent, but that's these pharmacists and other groups are not really trained at all within primary care during their training. They tend to be trained in secondary care or universities. So whatever happens, they're going to have to serve an apprenticeship, a bit like GPs do in the practice, to learn the way things work, the culture, the type of workload and cases we deal with.
Typically, how long do you think it takes for someone to come up the line and be fully effective without having to impinge unduly on yourself, for example?
Well, I think they'll always have to impinge on ourselves because there are aspects of our job and the broad medical knowledge to manage risk that is our remit. I would be anecdotally making it up if I told you a figure, but it takes at least a year for somebody to begin to really work within a practice. You could say off the top of my head, but that it involves just learning how they fit in with the team, and it takes a long time for these groups to embed within the team. And in some practices that hasn't happened, and that's been part of the problem. is that training and focus hasn't been allowed to happen within the practice.
Dr. Morrison, do you have anything to add to that?
Yeah, so a major problem with MDT implementation is that we've never had contract specifications. So there's been high level of variance in what is done at each practice level. Now, that contract specification would have been hugely helpful in instruction to the health and social care partnerships on what was required to be delivered and have consistency of approach and reduced variability. Instead, we have highly variable levels of service across every practice in Scotland. Now, it then becomes very anecdotal. Chris Williams mentioned APP as problematic. Advanced physio, in my practice, the advanced physio service is superb, and we would absolutely cherish it. And it would be a real loss to us because we can triage direct into any musculoskeletal condition, and we have full confidence that they will handle it well and autonomously. But that, is an example of how it can be, but it's not replicated across Scotland. We do have other areas of the contract where there is definite culture clash when entering into primary care. The general practice culture is one of risk absorption and acceptance, where we make decisions based on benefit risk analysis and then continue with that. Whereas some other elements of these services, as soon as they identify any risk, withdraw from provision until that risk is resolved, when that actually neglects the benefit of the reason it was put on. So, there is cultural issues, there is workforce issues, and fundamentally there's this lack of specification that leads to poor guidance to the HSCPs on how we have consistency.
And any last words, Dr. Williams?
Just to clarify, the advanced physio or first contact physio is a fabulous service. I absolutely wouldn't have it taken away under any circumstance. It really offers something brilliant to our patients. But it's an example of a new type of service, and finding out how to use this best and how to use digital tools alongside it. We're still learning this.
Okay, thank you. Thank you.
Okay, thank you very much. And I'm now going to invite Stephanie Callahan to continue with this theme of the patient experience and other aspects of the Audit Scotland report. Stephanie.
Thanks very much, Convener, and thanks to everyone in the panel for joining us today. It's much appreciated. So I suppose we all know that general practice is changing, but the difficulty lies in getting that message across to patients, having them understand the kind of evolving roles of those multidisciplinary teams, that it's not necessarily always the best option, number one, to be having an appointment with the doctor, that they may be better having an appointment with another member of the team, because a GP appointment just means that they're then going to be referred on, so they're kind of waiting twice there. So I'm just wondering, and we have spoken a little about this already, I'm wondering how well you think patients do understand the evolving roles of multidisciplinary teams, if you could say a bit on that, and if I could start with Dr. Williams. Thanks.
I would fly the flag for continuity as well. We know that when we can find continuity for our patients, especially continuity with a GP, that their outcomes are much better and their experience is much better. I mentioned before the efforts that we've gone into in individual practices to try and make information available. I think our patients, many of them feel as if they are being redirected, rerouted, fobbed off sometimes when they think they're asking for the right person, and they're explained to use a different part of the system. I'm grateful to our Chief Medical Officer for mandating that practices have websites, and there was a period of work where the NHS 24 team had helped practices that didn't have websites to have a recognisable format and the similar types of useful content on websites. But not all practices have got clear explanations on their websites about how to see different types of professional.
So I'm wondering if you could just expand on that a little bit and say what differences have you seen those kind of websites making on the ground? So
I think, first of all, for patients to navigate, to understand the hours that a surgery is open, or how many different GPs are there. You might think it obvious, but there are changes. And so having an updated information repository for each practice is helpful. But without overwhelming or overloading patients, I think having clarity is useful. And I think also when people are carers, if they are seeking appointments for their elderly relatives, for example, I think it can be frustrating for them to find that the practice that their parents are registered then operates differently from their own practice, for example.
I appreciate that. Is there anything from Dr. Morrison or Dr. Proven?
Research supports the fact that patients don't know about the changes to the multidisciplinary team. We've had lots of new skills. Again, physiotherapy has been a success in my practice too, and GPs themselves can do whole person care though, and that often patients come with more than one problem, and you deal with that in a very efficient way, and you get to know the patient and that continuity. My concern sometimes is how we manage within the MDT the fragmentation of care, where you go to a different person for different aspects of your care rather than the whole person, because the research shows that continuity it really is a very effective tool for patient satisfaction, for outcomes for patients. So how do we get that balance right with continuity?
Sorry, thanks. Thank you for the question. And just to reiterate that when we speak about the patient journey, it is far easier for patients to associate GP as the first point of call in the start of their healthcare journey. And there's a real risk to health inequalities when we try and introduce multiple layers or different services, because it becomes increasingly confusing to navigate that. Now, it's fine if you're very health literate and are able to, self-navigate, if you like, but the NHS can be a very daunting experience. And, having that first point of contact, general practice, has been shown to be very effective in getting it right for the patient first time. So, yes, the MDT can be of assistance with the ongoing management, but I think we have to hold on to that first point of contact element and the continuity relationship-based care that we know has massive improvements in health outcomes and can address health inequalities also.
So I think that's really interesting that all of you have mentioned how important that feeling of continuity of care and the trust of patients is just an absolute priority and so important to their well-being. I will touch on health inequalities later on there. So I'm wondering, in your view just now then, what action should we be taking, should the Scottish Government be taking to help patients actually understand those evolving roles in the multidisciplinary team and to help build that wider trust?
So it is quite a difficult message to get across in any sort of public messaging campaign. We have, there was some letter drops about across NHS Lothian, for instance, where it described the various services available. But did it really change a lot of patients' flow? It didn't. We know that health messaging can be very difficult to get across, and we know that it's adopted at very different rates across deprivation groups. So if you take for an example, Baby Back to Sleep campaign, it took 6 months for the most well-off in society to adopt that campaign immediately. It took 15 years to see the similar uptake in the most deprived in society. So this type of messaging takes a long time to get through, and I genuinely believe that we have to continue to see general practice as the first point of contact, but from there may be a different pathway, which it's up to practices to educate patients with on how that is the best for their needs.
So I would be interested then in, are there any positive examples that you have just now of GP practices where that has been working quite well? And are there lessons that we can learn from that? Are there things that could be information that could be shared that would help improve it across the board? So
there are a number of practices that use various triage tools to try and give patients a faster care pathway, but that maintains that first point of contact element. That may be something that could be explored, but we do have to have some sort of focus as well on that continuity relationship-based care, because we know that is what really drives the best outcomes in society. And it also lets us address with the quite often within general practice that the presenting complaint is not the main driver of the consultation. It's we call it the hidden agenda. So, the sore knee might actually be a lump that the patient is worried about elsewhere in the body. But if that is just instantly put to a physio, then that lump may not ever get addressed or in a timely manner. So, we need to, have a bit of capacity to be able to be that first point of contact and deliver that continuity relationship-based care, but then use the MDT as and when required when they give best value. Thanks.
I'd be happy to take any comments from other doctors if they have.
I might come in and just explain so our patients don't always react well to being redirected to other parts of primary care. For example, there's been a concerted effort to try and help guide people who have got an eye problem towards an optician, or people with a dental problem towards a dentist. There are some difficulties where patients aren't registered with NHS dental practices, for example, or other difficulties in the route towards a practitioner of choice. And I mentioned in terms of the physiotherapy that's a very different thing. That we have a new role and a new service in house, and so that takes a different form of explanation. So even say for something that we're so proud of, we find patients still thinking that they need to see a GP. That might have been the way that they've accessed physiotherapy through an onward referral in the past, but and also to try and explain to patients that these advanced practice physios or first contact physios have a diagnostic role that the community physiotherapy service didn't really have in the same way before, and they're doing injections, they're doing new things. But it's how we get the good news messages out, as well as how we try and help people to parts of the system that can absorb, that have relative capacity to absorb the work.
So, if I could just ask you, Dr. Williams, do you think are there any specific things that you feel the Scottish Government should be doing at this point in time to support you?
Like Dr. Morrison, I see the difficulties in trying to run multiple public information campaigns. In the past, we've asked Scottish Government to for assistance in this, and so I'm acutely aware that there's other bits of work that might be in train. So I'm aware that there's issues around resourcing, around timing, and about not bombarding the public with too many messages, especially if they might conflict. But I do think we want to help our patients know how to use our health service.
So it sounds like the GP's trust and confidence. So, for example, when you're talking about physiotherapy there, and your confidence in their expertise is something that perhaps plays a role as well in this. So I'm wondering as well if there's anything for the Scottish General Practitioners Council. Do you feel that what else could they be doing to help tackle this issue?
Tackle the issue of patient confidence, you mean?
Yeah, sorry.
Okay. Well, I think that again comes down to the messaging at practice level when it is delegated into the physiotherapy service. So, as Dr. Williams mentioned, the diagnostics element is something that when you tell patients that the physios can organise x-rays, they can refer into orthopaedics as required, then that alleviates any concern that they are not getting a full service by not coming to a GP. So that then gains confidence and trust, and where that is then experienced and they have a good experience, then that is embedded and they're likely to tell a few friends and so forth. So there's a positive cycle there. How that could be done at national level, well, again, because how it is at every practice level is so highly variable, and it might well be that in my practice we triage into the physio. In other areas there is direct contact to physio out with any practice control. It's impossible to give any national messaging. So what government could do is push ahead with the contract specifications in order to have a standardised process and expectation of what should be provided to GPs, and a service that is autonomous and reliable, where GPs are not the backstop, which then means that we can have consistency of approach and solid public messaging.
So, sorry, I'm happy for someone else to come in, but I'm really interested in the Scottish General Practitioners Council actually supporting GPs to provide those effective comms and to tackle that negative narrative that there is around GPs just now. So if you could include that would be great. Thanks.
So I was just going to comment that patients want to know that we're all actually working as a team and sharing information on our skills. Because I was talking about, for example, a physio waiting to have a conversation about a patient with me in between patients, and that is really good use of our time. But I need to trust that physio in the way, again, that they risk manage the situation. And one of the barriers to that is around premises, where 80% of practices in a recent survey said that there's not enough consulting rooms. and the MDT works best when it's in the same location. Otherwise, you're not members of the same team. And that's, I was just going to say, is a barrier to things. I think, my own view, it's difficult to put out a single, even a multiple campaign to inform patients, because they won't really know until they actually need to interact with our services, the change. And then at that point, they will have to, because of their experience, they'll have to learn how to navigate it, which can be difficult for some groups.
Okay. Thank you. So just moving on then, a little bit about GP clusters. The Auditor General's report stated that the Scottish Government has had limited progress, and I think that's something that can be agreed, in creating the necessary conditions for the GP clusters to succeed. So I'm wondering, in your view, what the impact of the recommendations in the 2019 guidance on GP clusters not being implemented or fully funded, if you'd like to comment on that.
So the guidance is there really to support clusters as far as having enough administration and list server support, as Chris Williams said, around data, and really a culture that they will be supported by the Health Board and listened to when they come up with suggestions about service changes. But our recent survey, along with the BMA, showed that there's not enough time really for clinical leads to carry out quality improvement activity or bring their teams together. There isn't really enough support for PLT, for learning around practice, protected learning time for practices. So really, we don't need to reinvent the guidance. We don't need another round of reviews. We just need to think about how we actually implement what we're doing. There's a huge amount of quality improvement work going on already 400 projects. So, and the research shows that the quality leads want to do more in the survey, but they don't have the infrastructure, the time, the headspace to be able to do that. And when GPs come up with saying, well, why don't we do things differently from the clusters, because that's one of the roles, is in suggesting service changes, that they're not really listened to, which frustrates them and means that they don't actually carry on producing ideas when they're not listened to. So we need to really think about how we relaunch and re-empower those clusters, because the evidence is that that system works professionally led to improve patient care.
Great, thanks. Any further comments on that?
I might come in just to build upon what Dr. Provins said, that there is this desire from our cluster surveyed cluster leads and demonstrated this, and demonstrated a inconsistent support, and that further resource would have advantages. And just supposed to highlight, it's not only Scotland that does cluster work. This is an established way of improving quality, improving our services by as one of the of building bridges between practices to try and help improve consistency and understanding of each other. And again, that the protected learning time would be one way to improve cluster working, to improve integration of MDT members. Thanks.
Can I just come in to support Dr. Williams there on protected learning time? So we used to have 10 afternoon sessions per annum with NHS 24 cover. That's been withdrawn for a long time now, with NHS 24 refusing to cover even where local out-of-hours services would support GP practices to take the time. We have also seen a complete flatlining of the practice quality lead remuneration. It's not been uplifted since 2017, so there's been significant inflationary erosion there. But, you know, as much as we can have our cluster meetings and have some of the practice quality lead time, without PLT, it's very hard to scale and spread that across practices. So you need that dedicated headspace to work with your entire practice team to make practice systems more efficient, more productive, and make the patient experience far better. Thanks.
So I suppose just on that point, I'm really interested, Dr. Morrison, do you feel as if having those 10 afternoon sessions back, would that be something that would make a huge impact for you, or have things moved on from there and it would be something different that you would be looking for?
You know, it's with real regret that the loss of PLT coincided with the 2018 contract, because it would have been ideal when we're having, you know, new members of the team added into practices to have proper integration, headspace to work together, to work out patient flows the best way, to work out patient communications the best way. That was not, you know, an opportunity given to practices. So it would be welcome to see a return of it, and, you know, to work together across that entire MDT space to make the patient experience much more smooth and better outcomes for all.
Thank you.
Stephanie, we're quite short of time, and I wonder whether, if you're agreeable, I can move on and invite Graham Simpson to put some questions to the panel.
Yes.
Thank you so much. Thank you. Graham, over to you.
Yeah, many thanks, convener, and good morning, panellists. And I should say that Dr. Morrison and I have also met, as well as Mr. Beattie and Dr. Morrison. We had a chat on Friday, and that was very useful. So I just wanted, if I may, just to go back to the convener's first question about the First Minister's announcement of an extra 100,000 appointments in GP surgeries focused on things like high blood pressure. Now, I must say, when I heard that, I thought that was a load of baloney, because when I get my annual blood pressure check, it's not with a GP, it's usually with a nurse. I have a choice of a couple of places I can go in East Kilbride, where I live, so I choose one. It's actually not at my GP practice. Go along, have my blood pressure taken, and they'll, you know, they might do a blood test as well. Check my weight. Last time it was a bit alarming, so I need to do something about that. But I'm not seeing a GP, so that's not really, you know, that's not really getting people to see GPs, is it?
No, there's the practice nurse would be running this program, which is designed to actually reach hard to reach populations for screening around the cardiovascular health, which is a good target because there's evidence that that is a difficult group, but it's not frontline GP appointments. We welcome any increase in the percentage of the budget moving into primary care, but as Dr. Morrison said, it's really a tiny proportion, and we need a step change in the way we're doing things.
Okay. So do you accept, well, maybe all three of you, do you accept that there is an issue with people not being able to see GPs, and that's not necessarily GP's fault? I'm keen to explore the reasons for that. There is difficulty with people seeing GPs, and maybe it comes down to the fact, and I think, Dr. Morrison, you've made this point in recent days, there are not enough GPs in Scotland. I
wouldn't necessarily agree with there's not enough GPs. There's not enough core funding to employ the amount of GPs that Scotland requires. Now, we recently did a BMA wellbeing and funding survey. In that, we asked our locum community if they were underemployed. A very large proportion of them said they were, and we identified 180 whole-time equivalents of underemployed GP time. Now, that's just the locum market, and the locum market is very much the canary in the coal mine of overall general practice provision. So if the locum market is struggling for work, then there will also be less substantive posts within general practice on offer. And where GP partner drawings are falling or not keeping a pace with the intended DDRB uplifts, which we've seen for several years now, then those GP partners will generally reduce their sessional commitment in order to offset the financial loss. So there is a huge amount of GP underemployment across the system, which could be restored with core funding as the only mechanism by which that time can be realised. So there is far more capacity available than is currently being provided.
So we've got the situation which you've described earlier of people training to be GPs, being qualified as GPs, but being unable to get work as GPs. And you, Dr. Morrison, have just said that locums are underemployed. So you've got this number of people trained, maybe in Scotland, presumably in Scotland, unable to get work. Now that seems a crazy situation to me. Are you able to put a figure on that? Do we know how many trained GPs are just sitting there unable to get jobs?
So 180 whole-time equivalents by our survey. So that's more than 180 people generally. So we need to move away from talking about head counts when we talk about GPs and focus very much on the whole-time equivalents as a better understanding of what is provided to the system.
Yeah, but I am interested in the number of actual people who are trained to be GPs who can't get work.
Several hundred.
Several hundred.
Are underemployed, not unemployed.
Yeah.
They are getting some work, but not as much as they could potentially offer.
Dr. Provan.
It's just to say that we have increased the training numbers in Scotland, which is welcome, but there hasn't been really a thought-out plan as to how we retain that workforce within Scotland at the end, because we need really the funding and the infrastructure. There's been pressure around inflation and increasing charges to practices. The national insurance situation didn't help. All of these coming together mean that practices are not sure about whether they can spend and moving forward. The report, the Audit Scotland report, says certainty around medium-term funding. That would be very useful if we could really know what the funding situation is and think of a plan about how we can make use of these highly trained, highly skilled GPs, some of whom who have come up from abroad to train here are very welcome. International medical graduates, we're trying to make them really welcome so that they put down roots and support us moving forward. Just to mention the visa situation, it makes it difficult for them at the end of the training. It can be difficult and stressful for them to have to apply for a visa after they spent many years training in this country. But we want to support all GPs, and because we have great people coming through, but we can't employ them.
Yeah, it strikes me as a ludicrous situation. And Dr. Morrison, you've identified that there is a £290 million funding gap. So if the Scottish Government was to come up with £290 million, what would that get us, do you think?
I think we'd see a significant increase in the GP whole-time equivalents across Scotland because, GPs are exhausted by the intensity of the workload, and the only way we can truly offset that is by having more colleagues work alongside us to spread that workload in a more sustainable manner.
Can I just say that extra funding would reduce the number of patients per GP, and many of my colleagues, my age group, have retired because of the intensity of the job, and people coming through are finding it difficult. In a recent survey, 67% of our two-thirds said that patient safety was potentially compromised by excessive workload. It's just the pressure of seeing patients, and we want to provide a service. I'm fitting patients in here in left who I've known for many years because I want to provide a service, but it's very difficult because we only have a certain amount of time in the day. So that funding would increase the number of GPs to be able to manage risk in the community, and all of the policy documents talk about more care taking place in the community. If we're going to do that, we need to provide the infrastructure for patients to be able to do that.
I mean, that statistic you quoted there of two-thirds of your members saying that patient safety is compromised is extremely alarming. It really is. And Dr. Morrison, your own survey, I think you issued a press release over the weekend, says that a large number, I think it was around half, say there is no realistic chance of meeting demand from patients.
That's correct.
That's astonishing. So how do we rectify that?
So it is rectifiable. We have made a position statement which identifies, what would happen if we had the inflationary restoration, then look towards a move towards budgetary restoration of 11%. That would transform the face of general practice and allow us to get a whole-time equivalence down to a patient list size of about 1,000, currently sitting at 1,760. That would mean more time to spend with the people that need us the most to provide proactive, preventative care, which has huge knock-on health economic benefits. £1 invested in general practice returns £14 to the wider economy. Now that is supported by the King's Fund. We've also got a paper called The Value of GP, produced by the BMA, which identifies lots of international evidence on if you get the general practice primary care medical intervention right, then you save huge amount of health burden on the nation.
Okay. Now, can I ask all three of you? We don't all three have to answer this, but one of the big issues which comes up in political circles is the so-called 8 a.m. rush. So you know what I'm talking about. It's a booking system that some GPs, not all, but some operate, where in order to get an appointment, you have to phone up at 8 a.m. And quite often it will just be for appointments that day. Now, Dr. Morrison, when we chatted on Friday, I was telling you quite honestly that I was registered with a GP that had that system, and I realised that just meant that because of my working practices, I would never be able to see my GP ever again if they persisted with that system. So I changed GPs. And I now have one who doesn't operate that system, who I am able to see. I mean, is that something that you recognise as being a problem?
Absolutely. These practices, try and adopt their systems to suit their local communities. But, whilst there's a demand capacity mismatch, then there's always going to be victims of that. So, until we address capacity, then we will always have this 8 a.m. rush because it has become endemic. Now, if patients had confidence that they could phone at any time of the day and get an appointment because there is capacity within the system within a time that is suitable to their needs, then they would very quickly know that they wouldn't have to enter the 8 a.m. queue. But whilst there is not that confidence, and whilst there is this, rush, it's very hard for practices to overcome that. It's impossible for any practice to answer several hundred phone calls in the first 30 minutes. Yeah. So it's inevitable that there are, very long call wait times and then added patient frustration and so forth. So which makes the whole patient experience poor. But the solution is addressing capacity. Thanks.
Dr. Williams.
Yes, I absolutely agree that the demand and capacity mismatch is what we're suffering from here. There are some ways that you can smooth some of the peaks in demand. So there are the digital telephone systems can help. Having forms that people can submit to explain more about their current inquiry or medical problem that they have, or to try and be able to assist with triaging the inquiries. But essentially, if you have got a large section of your population that have got lots of reason to be contacting the practice, then the practice has to somehow absorb that, somehow sift through what needs to be dealt with straight away, what might better have been dealt with by another part of the system. And I think general practices have responded admirably to that. But such is the level of demand and the level of need of our registered populations that it's very difficult, even after practices reorganise their appointment system or try to influence our patients' behaviour. It can take months and years to try and bed some of the sort of changes in behaviour of our patient population. And I think Dr. Morrison adequately summed it up. If they could trust our system, then we'd be in a much better place. But we need greater capacity. We need more GPs.
Okay. And do we have any data on how many practices operate this system?
No.
And why is that?
There's 900 practices across Scotland. They're generally independent contractors. They have a duty to provide care to the undifferentiated, undiagnosed, but there is no, set contract formation on what mechanism there is to deliver that. So there is high variability, and most are driven by the needs of their local population. The demographics are highly variable from practice to practice.
So the data question is quite important, though, isn't it, for the rest of the whole of the NHS? It's quite, it'd be good to know how many patients GPs are seeing, what the booking system is. That's only part of it. How many people are going through the system, what they're being seen for. And I believe that in England, GPs are now required to provide a certain level of information and are doing it, but not here.
No, again, I just want to emphasise the first point is the capacity issue around practices, and most practices will actually look at their population and try and work out a system where you have triage and then you have book ahead appointments suitable for their local population and the capacity they have to get to the patients who actually need care the most. You're talking potentially about targets for access. We would not favour that because the whole situation is much more complex than that. And you can't just say that everybody needs to be seen within a certain period, because we don't have the capacity to do that. What practices are doing at the moment is their systems of triage and actually triaging to other members of the team allow us to get at the patients who need to be seen that day. But we're always wanting to work with practices around situations like, one example would be how you could use the clusters to reflect on their appointment system together and learn from each other. Also, fast access, we want to temper that with that continuity that we keep coming back to, because actually if you see the same person, you don't have to tell your story again. It's a better experience and you don't have to go round and round in the system. Yeah. GPs themselves acknowledge the difficulties that patients have getting an appointment, and we feel that as well, because that's why we get up in the morning. But there's really difficulty with the capacity around that, and it's a complex issue, the whole issue of access.
Now, can I go to Dr. Williams, because Dr. Williams mentioned websites and IT, and looking at some of the websites that I see around Lanarkshire for GP practices, they're not as advanced as those that are south of the border. I mean, my mother, who's in her 80s, she lives in Carlisle, and if she logs in, logs into her GP practice, she gets a lot more information than I can get, a lot more. And I think she's actually able to book appointments online, but she can get details of what drugs she's been prescribed. I can't get any of that in Scotland. So we seem to be in the dark ages here. Is that fair?
Happy to shed some light on the background. So that there are some online patient services, and for example, the practice's website will then link to a further website in order to do that. So it's not the practice's own website, but there are ways, as you pick up on, of ordering prescriptions, for example, seeing what prescription items you've ordered recently. I'd mentioned the project where NHS 24 were helping practices to develop websites, to have access to ready-made websites and material. There was some thoughts maybe 5 years ago that project might have some quite technical features, as you say, more advanced things might be available, that the websites might be able to do snazzier things. But as far as I understand, there was only limited funding, available to start that project, and I think there was a decision made round about simplicity of the websites that were produced. So there's a range of different companies that produce websites for practices, and I think moving to where we have the capability to offer online services, where we have the capability to help patients do things that they don't need to go through the practice telephone switchboard to be able to achieve. I think that is desirable.
What needs to happen to achieve that? Does that need Scottish Government help? Sorry, Dr. Morrison wants to comment on that.
It comes back to my previous comments about spine. So because we don't have that central repository with ease of access for multiple systems to speak to each other and feed from, that's how the English NHS app works, and that's how they can access GP appointment data, the prescription data, in some areas some of the healthcare record itself. There's also online systems such as Accurix, which is a digital solution to provide access into the practice and appointments in and out, which is widely disseminated across England. Scotland's gone from the first nation to have an electronic healthcare record, the first nation to have index linking of patients, to now really being way behind on health IT. England have had digital prescribing since 2010, and we're still looking at maybe 2030 now. We really are left behind.
Yeah, so I'm right about that. My final question, and it's to you, Dr. Morrison. We've got a situation where GPs are up against it. Some GPs are suffering burnout, stress. They're leaving the profession. We've got GPs who are qualified but can't get enough work. You've described a situation as some feel the service is on the brink. Are we getting to the stage where GPs are prepared to take action about this?
So I'm a mid-career GP and took on this role in August because I really do see this as a crucial point in our profession. I don't see a sustainable future on the path we're on, and neither do my colleagues. When we did the wellbeing and funding survey, 90% said they'd reached the point they would consider disruptive action. And from that to come from an incredibly altruistic group of doctors who want to do the best for their patients and their communities is really upsetting. I have spoken to the Cabinet Secretary several times about this. We see the 290 million as the mechanism by which we stop the sinking ship going under. But we do need to have a proper look at a much more optimistic and sustainable future for general practice. We believe that's deliverable by addressing the patient list size to whole-time equivalents, to realise the potential of general practice. The potential is incredible, and it is a wonderful career if you have the right time to do it. If you're able to build those relationships with your patients and see through their care journeys, it is an absolute privilege when it's performed well, but is really demoralising when you know you could be doing more and could be doing better.
Okay. And I suppose just to close, Convener, if you've spoken to Neil Gray about this and you presumably said to him, look, my members, 90% of them say they're prepared to take disruptive action, what's Neil Gray's response been to that?
We are speaking collegiately. He understands the pressures that we're under. He's spoken to multiple practices across Scotland. He's hearing the same messages. Essentially, it comes down to that core funding, the balance of budgetary decision-making, and, to realise that potential and rescue general practice. So we are working at pace with the Primary Care Directorate to, de-escalate where we are. I can only hope that comes to fruition. Thanks.
I hope so too. Thank you.
OK, well, thank you very much. Well, on that rather stark warning note, we're going to have to draw this session to a close. We did have some other questions that we wanted to put to you, but we've really run out of time. So what I would propose, if you're in agreement, is that we perhaps put those down in writing to you and make sure you get an opportunity to give us answers, because we didn't get on to premises and some of the other areas that we think are important to you and are a part of the 2018 contract. So with that, can I thank Dr. Chris Williams, who joined us online, for your input, Dr Chris Provan for being in the committee room and giving us the benefit of your expertise, and also Dr Ian Morrison. Can I thank you as well for your time and for the evidence that you've given us this morning. It's been a very useful session. I'm now going to suspend the meeting as we need to change over witnesses, but can I thank you all for your participation this morning, and I will now formally suspend the meeting. Well, can I welcome people back to the second half of our agenda this morning, looking at the Audit Scotland report into general practice, progress since the 2018 General Medical Services practice contract. And I'm very pleased to welcome with us at the committee this morning a team from the Scottish Government led by Caroline Lamb, who is the Director General Health and Social Care and the Chief Executive of NHS Scotland. Good morning. Alongside Caroline Lamb this morning is Tim MacDonald, who is the Director of Primary Care for the Scottish Government. We've also got Susan Gallagher, who's the Deputy Director of General Practice Policy in the Scottish Government, and Andrew Chapman, who is the Unit Head for the General Practice Contract and Operations, or is that Contact and Operations? It's GIS contract, yes, good, at the Scottish Government. We've got some questions to put to you. Stephanie Callaghan is joining us online, and I'll bring her in at the appropriate time. But before we get to our questions, Director General, could I invite you to make an opening statement?
Thank you very much. Thank you for inviting me today to discuss the Audit Scotland report into general practice. I'd also like to thank Audit Scotland for the report and to confirm that, as is our normal practice, we've engaged fully with Audit Scotland during the process of producing the report. The 2018 contract was a landmark agreement between the BMA and the Scottish Government. It represented our joint statement of intent as to the future of general practice. It was and it remains an ambitious, complex and major change programme with multiple work streams and timeframes in what continues to be an evolving delivery landscape. And as with any complex programme, there have been and remain challenges which Audit Scotland have helpfully drawn out. Our partners had different starting points and differing ability to operate at pace in implementing the change programme. Access to good quality data has been a long-term endeavour with known issues and risks. The significant impact of the COVID pandemic and a changing societal context with pandemic recovery, the cost of living and inflationary pressures, increased demand for GP services and UK-wide fiscal constraints all having an impact on progress. I don't shy away from the challenges identified in this report, but we must now build on what we've learnt and what we've delivered and focus on what comes next to improve access, quality and continuity in general practice. A key aspect of the contract was the development of the multidisciplinary team, creating a fundamental change to how we deliver the service in Scotland. And we have significantly expanded that workforce with over 5,000 staff working in those services as at March 2025. Recognising the importance of the GP workforce, we're also now implementing our action plan on GP recruitment and retention, which was co-produced with GP stakeholders and has been welcomed by the Royal College for General Practice. We've refreshed and published the Transforming Roles General Practice Nursing Statement, where we're being very clear about the value of general practice nurses in supporting people's health outcomes. And we've developed and published with NES a competency framework for practice managers, guiding them in the vital roles that they play to support practices and patients. And that's not all. We've also improved the data available in relation to general practice and invested in tackling health inequalities. But the work that we're doing in general practice doesn't stand alone. It's a vital part of the wider primary care ecosystem and of our broader health and social care system. Earlier this year, the First Minister committed to increasing investment in primary and community care, and yesterday saw the publication of the Service Renewal Framework and our Population Health Framework, which sets out our priorities of supporting a more preventative and community-orientated approach to health and social care. The primary care route map, which we've committed to publishing within the next year, will set out the detailed vision, outcomes and practical actions for primary care, including general practice, to deliver the Service Renewal Framework within the context of wider NHS reform. It's clear that many things have changed since 2018, and we need to reflect that in our future plans. The Service Renewal Framework, the Population Health Framework, and wider ministerial commitments are evidence of our commitment to reform and renewal. And general practice, alongside wider primary care, is central to that ambition. So this is an opportune moment to pause and reflect on the snapshot of delivery that Audit Scotland has provided, and to consider how we build on what we've delivered and the lessons learned so far to ensure that general practice has a bright future at the heart of the NHS. We welcome the committee's questions.
Thank you very much indeed for that opening statement. You said at the start there that, of course, the Scottish Government had engaged in the production of the report, and you also said at the end it was an opportune time to pause and reflect on the report. Do you accept the findings and recommendations of the report?
Yes, we accept the recommendations of the report, and we are already taking actions to ensure that we can deliver against those. Okay,
so you accept then the key messages which are set out at the beginning of the report, which include message 1, the number of GPs being increased by 800 is unlikely to be met by 2027. That you accept, presumably, that commitments that are part of the contract and were supposed to be completed by 2021 have still not been fully implemented, that things have been slower than planned, that the Scottish Government has not been transparent, that there is a lack of clarity, and that direct spending to GPs has decreased. So you accept all of those findings?
So I think that what I'm reflecting is that, as I said in my opening remarks, there have been a number of challenges to complete implementation of the ambition that was set out in the 2018 contract. And we accept, I've said that I don't shy away from the challenges in this report, that we accept that there is much more to be done, and there is work that we're taking forward, which I'm very happy to describe to the committee around how we're taking that forward. I'm sure you'll want to come on to ask us around each of those areas, around workforce, around funding, around data and monitoring, but I believe that we can demonstrate that we are making progress, maybe not as fast or as complete as we would have wanted to, but we are making progress in all of those areas. And I think what we need to do now, and what we are doing now, as indicated through the service renewal framework, is to say, OK, so what are the next steps that we need to take to make sure that we deliver general practice as part of that wider primary care environment that is sustainable and fit for the future.
Yeah, I mean, and we all accept that yesterday afternoon a service renewal framework was set out by the Cabinet Secretary for Health, but what we're talking about here is a contract which really has its roots back in 2016. I mean, I suppose I return to my question. Do you accept the findings that are contained in this report, which include criticisms of the government's tardiness, criticisms about the extent to which the government's been transparent?
I accept that we have not progressed as quickly and as completely as we might have wanted to do, and I think there are a number of reasons for that, not least of the fact that we had a COVID pandemic in the right at the early stages of starting to implement that contract. I think that, and I do accept that there is much more for us to do. There is more for us to do around data and making sure that we've got the robust data to be able to be transparent. And I believe that we're taking steps forward with that as well. Just yesterday, we had the latest publication around the multidisciplinary teams with the numbers of staff and the amount of funding dedicated to each of those 6 priorities. So yes, there is more for us to do, but I do believe that we are making progress.
OK, but I'm not going to allow you to get away with blaming the pandemic, because the consultation on this contract began in November 2016. The document was produced in November 2017. Phase 1 of its implementation began in April 2018. So that's almost 2 years before the pandemic. You really can't blame the pandemic for a failure to implement most of the objects which are set out in the contract.
I think it's important not to underestimate the impact of a global pandemic where necessarily all our capacity and attention switched to fighting that global pandemic, and the length of time that it took not just to deal with the initial waves of that pandemic, but then the subsequent waves of infection flowing through all of our health and care systems. So I don't think we should underestimate that. But there are other factors as well. I think, as I highlighted in my opening remarks, the implementation of this contract was also dependent not just on actions from Scottish Government, but actions from our partners, including health and social care partnerships and health boards. And it's clear that not everyone was in the same place in terms of the ability to take that forward rapidly.
OK, well, before I go to Graham Simpson, can I just ask you about one aspect of this report, which is contained in paragraph 100, where, and I've never seen this in an Audit Scotland report all the time I've convened this committee, but they say quite bluntly, and this was repeated when they gave oral evidence to us, that the Scottish Government in a press release in February 2019 had been misleading, because it had claimed that 172 loans to GP practices to improve or to purchase or to sell on their premises had been applied for successfully, when it turns out only 63 had.
Yes, so my understanding of what happened there was that in the process of producing a press release, there was an unfortunate summarising of the data, which meant that data that was about the number of practices that had applied was conflated with the number of practices that had actually been successful and in receipt of that funding. But I'm just going to look to my colleagues just to double check that is in fact the case.
Yeah. So yeah, that is in fact the case, Caroline. So when we were developing the policy, this was a call out to practices, an expression of interest in the loan scheme as it was described in the contract, and that figure represents the number of practices who were interested in a loan at the time. The scheme was not live at the time, and as Caroline has pointed out there, unfortunately in the process of making a press release, obviously we work with our communications colleagues in government, with special advisors as well, it's come out as that. But in no way was there an attempt to deliberately mislead people with that press release.
Well, these are not my words. These are the words of the Auditor General, who said that the government had been misleading. And just for completeness, instead of £30 million being made available in loans, sustainability loans for premises for general practitioners, only £15 million has been loaned out. So that's a half of the headline figure that's in the 2018 document. Why is that? So
again, I'm going to refer you to my colleague Andrew, but my understanding there is about the readiness. This is also not just about us having the funding to give out, but the readiness of GP practices to be able to avail themselves of that funding. Andrew.
Yeah, I think that's broadly correct, Caroline. I mean, this is a novel financial instrument funded by financial capital. It relies not just on our goodwill as government, but on practices having all of their deeds in order, on banks, I suppose, who rightly kind of want to probe around the kind of status of these loans as well, kind of considering them and doing their due diligence in terms of kind of ranking agreements and whatnot. So there's been a significant amount of work on our part as Scottish Government, on the part of the Chief Legal Office of NHS Scotland, on the part of practices to get their paperwork and all and banks to get this scheme up and running over the last few years. But so it's not. It's and obviously we have been able to successfully complete on just over 60 loans, with another 40 in the pipeline, which are fundamental to the ongoing viability of each of those individual practices. So it's not. There are operational issues that we've had to work through above and beyond the issues to do with the funding being available, which obviously. There's been issues kind of centrally with UK government around the availability of financial transactions capital.
Right, OK. Well, I mean, it seems to me that this shouldn't have come as a surprise. At the time of the publication of the document in November 2017, it clearly stated the contract offer proposes significant new arrangements for GP premises. So there was an acknowledgement that this was pioneering, it was significant and it was new. So I'm a little bit puzzled as to why some of these difficulties have come as a bit of a shock to the government. Anyway, I'm going to move on now and invite Graham Simpson to put some questions to you.
Thanks very much, Convener. Before I get into my questions, one point I would make is when you're putting out a press release, somebody should check it. Do we not have a proper system in place to check the information that's going out in government press releases?
So yes, my understanding is absolutely we do check. There is a process of backwards and forwards in terms of ensuring that interpretations that have been put on information by our communications colleague aren't actually leading to misleading statements. This one obviously missed that.
Okay. You probably didn't see the whole of the last session, but we ended, well, actually it was pretty stark, the whole session was, but we ended with the figure from the BMA that in a survey of their members, 90% of their members, GPs in Scotland, are prepared to take disruptive action because things have got so bad out there for doctors. They're under stress, they're suffering burnout, there aren't enough of them. How have we got to the situation where 90% of Scotland's GPs are prepared to take disruptive action?
So the first thing I'd say is I accept that the BMA are concerned about the level of funding for general practice, and ministers continue to be in discussion with them around that. I think that we have, as Scottish Government, been doing a lot to try to support general practice. So on the funding issue, we have increased GP funding for every year since 2018. And I think what we need to remember is that the 2018 contract was premised on an investment in a multidisciplinary team with the objective of releasing capacity and releasing time for general practice. That, as I said in my opening remarks, that team now sits at over 5,000 people working in a way that is designed to free up time for general practitioners, and the figures that were published just yesterday or the day before demonstrated an investment in that team of 200 million. So I think there have been things that we've done. We've also successfully implemented the element of the 2018 contract, which was about the funding formula for general practice, reflecting workload and particularly reflecting the implication of working in areas of deprivation on workload. And we've also managed that minimum income expectation. But I do accept that I think we would all accept that the demand on GP practices has increased, and that is partly to do with the fact that the demand on health services in general has increased, partly as a result of the backlog from the pandemic. And so what we're seeing is that GPs are picking up the pressure of people wanting more support from their general practice whilst they're waiting for support in other sectors. I think that we also recognise that multidisciplinary team has maybe not been alleviating the pressure on general practice in exactly the way that was envisaged when the contract was agreed, and when the BMA also believed that was the thing that would make a difference and release time for general practitioners to be that expert generalist. And that's why we put in place the primary care phased improvement programme, to enable us to really get under the skin and understand what it is what a good high performing multidisciplinary team looks like. We also recognise that the contract had an ambition to move activities away from general practice, and to have those activities, vaccinations being a case in point, delivered by health boards. And some of that work has been very successfully delivered. And has been done without us in any way adjusting the funding to general practice for that. But there remains much more to be done. I think we are currently in a position where it is not just general practice, it is every part of our health and social care system that are under pressure. I don't know if any of my colleagues want to add to that.
Thanks, Caroline. If I could just come in to say both the BMA and our CGP are core to the dialogue we have with the professions about improvements and change that we can put in place. So I think the 2018 contract is not just a government endeavour. We have quadripartite governance with the BMA, with the NHS and with chief officers in health and social care partnerships to try and get the contract implemented and to work through some of the challenges that underpin that survey that you've just referenced. And I think Audit Scotland themselves recognise that that governance and that governance improvement is welcome. And for me, working through those challenges together with partners in the profession, looking at the future, not just of core funding to general practice, but how we get the phased investment programme taken forward on a national basis. And Caroline also refers to pressure. I think the work that we've tried to do on recruitment and retention, and there was a plan published before Christmas trying to cover many of the aspects of that, are attempting to meet some of those challenges being expressed by the BMA, not just in their public appearance here or their surveys of members, but also in their private and continuous dialogue with the government. And I think for me, reflecting on that and ensuring we learn and take forward the lessons from Audit Scotland will help us to make sure that we alleviate and move forward to address those pressures.
Well, we also heard that in another survey of doctors, 2/3 say that patient safety is being compromised. So you've got 2/3 saying patient safety is being compromised, 90% think prepared to take just disruptive action. And when we look at funding, the BMA are saying there's a shortfall of £290 million. What's being done to address that?
So I think the first thing I'd say is that the work that Tim's just referred to around the primary care phased improvement plan is around about trying to establish what a good multidisciplinary team looks like, given that that was the original agreement between us and the BMA back in 2018, that's what we would invest in to try to alleviate some of the pressures on general practice. And there are really good examples in some systems of how the multidisciplinary team is doing that. But what we need to do is to understand how that team best works, and therefore to drive the level of investment that is required. And I think we would all accept that more investment is required, but we need an evidence base for that, which is why we're developing a business case alongside the running of that phased investment programme. We need to evidence that with what works well for people and what works well for people, both the workforce and indeed patients. So I don't think this is about a formula that suddenly gives us a magic number and that's what we would need to invest. It's about developing that business case and having the evidence base that demonstrates what is needed and what results we can expect from that additional investment.
Well, you might not want a formula, Ms Lamb, but the BMA have come up with a figure, £290 million. They've also come up with a figure for the number of GPs that are actually sitting without enough work. You've got people who are qualified as GPs in Scotland who can't find enough work. It's an astonishing situation. 180, I haven't finished. 180 whole-time equivalents. So doctors sitting there without enough work, and yet we need more doctors.
So the government invested £13.6 million last year into practices to improve recruitment and retention. And we are continuing to work, including with NHS Education, to identify the reasons why we have got GPs who are trained and who are not working. Some of that is around, so part of the recruitment and retention work is around identifying where those barriers to employment are, including, for example, for international medical graduates, where we need to put in place improved structures to ensure that they can access visas. But Tim, did you want to come in specifically on that?
So two things. Just, I absolutely agree with Caroline. The BMA's number does not include core funding, non-core funding that's gone into the multidisciplinary team. So that 2018 contract, those 5,000 staff that Caroline referenced in her previous answer, they equate to around 190, and on yesterday's numbers, 200 million of funding each year. So I think it's important to take core funding alongside MDT funding. We're engaging with the BMA in bilateral dialogue to try and find out what more can be done to target core funding in a way that addresses that very problem, alongside the work Caroline mentions with NES, to make sure that the pathway from training allows us to fill posts that are available and need to be filled within the system.
So, Mr MacDonald, do you accept that there is a problem of people qualifying as doctors and not being able to get enough work in Scotland?
Our own recruitment and retention plan identifies problems with how we make sure that the number of people that we're training translate into people that are both in and stay in the profession. So we recognise that.
You recognise that. So presumably you also recognise, and this may be difficult, but in order to achieve that, we will need more investment into GP services, which is what the BMA is calling for.
So I think there are two questions. There's what we do with the long-term MDT funding, which Caroline mentions we have a business case under development to address. There is core GP funding as well. And I do accept that that is a discussion not only we need to have, but are having with the BMA, with the Cabinet Secretary's full blessing. And that will address that very question of, have we got the right level of core funding in general practice alongside the MDT and the investment needed to deliver the 2018 contract?
I think Susan wants to come in.
Yeah, could I just come in, please, around the unemployment of general practitioners? It seems to be an issue largely in the Central Belt. I'm told that there are vacancies elsewhere in Scotland for general practitioners. And just to note that we are working with our partners to explore this further, and as part of our discussions around funding, to see what we can further do to support general practice within the Central Belt.
Well, why do you think it's an issue, particularly in the Central Belt?
I think we're not really clear on why it's a particular issue in the Central Belt, and I think that's something that we're exploring just now with our partners.
Shouldn't you be clear?
Well, if we ask the SGPC, they'll say it's to do with the funding for core practice.
That is what they say. That's the whole point of this.
As Tim has just pointed out, we're in active dialogue just now around core funding.
It all comes down to that. It's core funding.
I think we also have to be conscious that the same factors will apply as elsewhere. As Susan said, that you can see vacancies in the more remote and rural practices. So it's about ensuring that people are encouraged to work in areas outside the Central Belt of Scotland as well.
Okay, I'll just move my questioning on. And I think I've asked you this before. IT, and well, in fact, I have asked you before about having an NHS Scotland app similar to the one that they've got in England. Now, we explored this in the earlier session. It's quite clear that we're still way behind here in Scotland, as opposed to south of the border. The level of information that a patient can get by logging on in England is far more than here in Scotland. And the doctors earlier were describing, well, frankly, creaking IT systems here that desperately need upgrading. we heard about the spine system in England. We're just way behind. And you've come to this committee before, Ms Lamb, and have promised that progress has been made, and progress hasn't been made. Where are we?
So in terms of our digital priorities, there are three big elements. So the first one is the digital front door. So the digital front door, which is our sort of gateway into NHS services, is on track to be launched in NHS Lanarkshire in December this year. So that will be the first stage of the rollout, and we will then build on that incrementally with plans to roll that out across Scotland more broadly during the course of 25-26. The digital front door is being developed to enable access not just to health records but also to social care records, because one of the features that we recognise is that the importance for social care, for primary care and for acute care of joining up that record, and the importance for people of not having to repeat their story and their history again. So that integrated health and care record is the second of our big priorities. And the third priority, which is one that also impacts significantly on general practice, is around digital prescribing and accelerating the progress on digital prescribing in order to, again, release capacity in primary care. So the approach that's the approach that we're taking.
Yeah. So as somebody who lives in Lanarkshire,
yep.
I'm very interested in this, but I want to know how that's going to affect me as a patient, who uses a GP occasionally. What information will I be able to get through that app in NHS Lanarkshire? Will I be able to use digital prescribing? Will I be able to book appointments? Or is it not that? So
the first stage of the development of the app will allow appointments to be booked, changed, rescheduled in the hospital sector.
Just hospital appointments?
It will start off with hospital appointments and then will be extended into general practice. Following that, the starting point will be hospital appointments and being able to get test results and that sort of data through the app.
If you have a test at your GP practice, as people often do, will they be able to get the results through this app?
So the ambition is that over time you'll be able to get all your tests regardless of where they are taken, and that will also help that clinicians, no matter where you're seen, will be able to see that data as well if you're willing to let them do that.
So the answer initially is no. It's just a hospital app, really.
So
isn't
as
it?
with anything, we have to start somewhere and test it comprehensively before we roll it out.
Okay. You don't seem to have learned from what they've done in England. We are way behind here.
So I don't think that's entirely accurate. We spend a lot of time talking to, also my colleagues in the digital team spend a lot of time talking to colleagues in England, including looking to see what elements of their approach we can adopt.
Now, in England, as you'll know, I'm sorry to keep mentioning England, but they just seem to be more advanced in many areas. In England, you'll know this, GPs are required to provide a certain amount of information, and so that presumably allows NHS England to, plan better because they've got more data from GP practices. Why aren't we doing that here?
So the approach here has been to work with the BMA through the 2018 contract to support, first of all, consistency in data. When you've got over 800 GP practices, there are inevitably issues that arise about exactly how data is being recorded on practice systems, but also to encourage all GP practices to make that data available. And we've also been working with National Services Scotland to make sure that we've been building a national platform that will enable that data to be visible to practices, but also to be used, as you say, for research, for planning of services. I think it is the case, and I'm just looking to my colleagues for confirmation, that we still have a position where not every GP practice makes their data available, and we continue to work with the BMA to look for their support to actually increase that coverage.
We're looking at Mr. Chapman there for.
I'm just. I don't know if any of my colleagues want to add to that.
No, they don't.
Susan, yeah.
Could I just come in terms of what happens in England? I think it's important to remember that the contract set up in England is different from Scotland, and that then enables England to have more specific information from general practice than the way the 2018 contract is designed. And we can talk a bit further about that, and I'll pass that over to my colleague Andrew if you wish to ask more around that.
No, you're absolutely right. It's a contractual arrangement. I just don't know why we don't have it here. Why we haven't tackled it.
Because the contractual arrangement is as set out in the 2018
I know it is.
contract.
I know it is. But then they've got a different contractual arrangement in England, which allows NHS England to get more information from GP practices. I just don't get why we can't do that here. We don't even know, for example, the number of hours that GPs are working in Scotland.
Sorry, can I come back?
That sort of basic information. We don't know. I'm on a roll here, Ms. Gallagher. We don't know, for example, how many GP practices operate what is described as the 8 a.m. rush, that appointment system. And we asked about that earlier. We don't have that information. Don't you think we should?
I think we do need to have more information, but it's working in a very much a strong partnership model here. And in terms of the number of hours that GPs work, we know how many sessions they do, and we're currently examining having more information around the length of those sessions.
Is that it?
No, so we continuously look to see where we can improve our data sources, but a key thing here is working in partnership with the profession.
Well, this is just a buzz phrase. It means nothing. We don't have the information. Mr. McDonald's coming to your rescue, I think. I was going to try to. Yes, that's my last.
So we do have data which shows both monthly GP activity data, which we publish with Public Health Scotland. We know how we are tracking every element of employment and output from the Primary Care Improvement Fund. And when it comes to teeth, under current regulations, we can direct health boards to request data from general practice to help with that planning and management activity. And that has to have a consultative element with SGPC. I think what we need to do going forward, particularly as we consider the next phase of the phased investment programme and also core general practice funding, is how we link further and better data to outcomes. And that comes to a broader discussion, not just about data, but about the role that general practice can play within a reformed health and social care system. So I think for me, I have seen in my tenure since 2021 a progressive improvement in the overall data, particularly at a macro level available in general practice, now broken down to health board level on a monthly basis. We have a very good dialogue with the SGPC under the GP programme board to try and improve data quality, data availability, and I want absolutely to link that to the funding dialogue that we're having at the moment.
Thank you, Convener.
Thank you. I'm now going to invite Stephanie Callaghan to put some questions to you. As I mentioned earlier on, Stephanie is joining us online, but she's got some questions, I think, to begin with around access to GP services. Stephanie.
I'm hoping you can hear me okay. My sound was a bit strange earlier on.
Oh, that's fine.
We can hear you. We can't see you, Stephanie, but anyway.
Oh.
There you are.
Thank you.
Proceed.
Caroline, I'm wondering if you can explain the reasons that patients are struggling to access GPs and why they're less satisfied with GP services since 2017-18 comparatively.
So I think the components of access are around having the right capacity, so having the right workforce and availability, and having the right processes in terms of within a practice being able to triage people, to be able to manage appointments, and also being able to sort of manage demand. And we have, I think, as Scottish Government, and through that contract, taken action, as I've already described, to significantly increase the number of multidisciplinary team professionals available to practices. So on average, each practice has access to 5.5 members of a multidisciplinary team, and to support practices in ways such as NHS 24, setting up standard websites for them that they can use to help patients to understand the services that are available and to access those. So I think we've worked quite hard to try and create the conditions that support access as well as possible. It is the case that there is significant variation across the country, though, and I think we can all tell our own stories or anecdotes about how hard it is or how easy it is in some cases to access GP appointments, or to access an appointment with the right appropriate member of the multidisciplinary team. And clearly that's not something that we wish to see. We would wish to see far more consistency across Scotland. One of the reasons that we've been working through this phased investment programme is to understand the things that help to make access easier and faster. But also there's other work going on with Healthcare Improvement Scotland, running a collaborative across primary care with encouragement of our health and social care partnerships to learn from each other in terms of what works well, in order to try and actually reduce the variation across the country. And clearly data is absolutely essential to that as well. Anybody want to add to that?
Yeah.
Andrew?
Yeah, I'm very happy to add to that. I think from the patient perspective, I completely get it. One of the key frustrations is that it's been kind of characterised as this 8 a.m. rush, right? Why can't I get through in the morning? Why can't I see my named clinician in a timely fashion? However, I think it is just worth mentioning that access in and of itself is an extremely complex issue when it comes to general practice, with many facets, each of which we're trying to do something about. So obviously there's that increasing the capacity. We completely get that and are in dialogue with the BMA at the minute on that point, just building on kind of what Mr Simpson was saying earlier. There's the processes, aren't there? So we've mentioned, for example, our support around digital prescribing is really key to free up some of the administrative burden around practices at the minute. There's the support, the transition to digital telephony as well. We put in a bit of money throughout the pandemic on that and continue to support practices on that path as analogue is switched off across Scotland and the rest of the UK. There's reducing demand on general practice as well, and all of the initiatives that we have in place around the MDT, but not just the MDT. I mean, Pharmacy First as well has been a really successful initiative in terms of alleviating some of those more kind of minor concerns that patients have, that in the past they would have gone to their practice for kind of ointments and kind of lotions and whatnot, and now can just engage directly at the counter their pharmacists on. I think what's really important as well, and that was trailed in the operational improvement plan, is quality and just kind of more clear and of course reasonable expectations from the public in terms of what they can expect from their GP services, which is why there was the commitment in the operational improvement plan in January to develop a quality framework which would do precisely that. It would create that clearer and reasonable, again, I kind of hasten to add expectation on the part of our public in terms of what they can expect from their GP services, and that will all be part of that dialogue that we're having in partnership, not just with the profession, through the BMA, through the RSGP, but also through our governance arrangements with health boards, and we're, of course, ultimately responsible for the day-to-day management of contracts and ensuring that those access arrangements are in line with what they expect for those contracts, and our health and social care partnerships, our commissioning bodies. So completely get the frustration around the 8 a.m, and it's just to point out that there's quite complex reasons behind that, and for each of those reasons we have initiatives in play as to how we are driving them forward, which ultimately will improve access for our public.
So presumably as well then that's about increased pressures with the older demographic increasing, and also secondary care, the waiting lists there. We've heard earlier today about the impact that that's having there as well. I'm also interested in what plans there are in place to improve the public's understanding of the changes to the ways that services are provided, which we also spoke about earlier today.
So I think that's a really important point in terms of that, communication with the public around a range of ways in which the way in which you access health and care services has changed. So I think the publication of the service renewal framework yesterday is an important moment in terms of being able to sort of re-trigger that discussion around what people can expect and what services are going to look like, and what are the changes that need to happen to services, so that people understand that value of the multidisciplinary team. They understand where to go for help. So as Andrew's described, Pharmacy First, I think, has been a really important development. We saw through the pandemic just how much pharmacies are sort of trusted points in the local community for advice and support. But we need to, and we will continually work with our health and social care partnerships and others to ensure that we're building on the messages around getting the right care in the right place, but building on that in order to add to that understanding about what's different and how best to access services.
So I'm just wondering, Caroline, whether that's enough, because we were hearing earlier on that the continuity and trust and that personal relationship with GPs is something that's really, really important for patients. So I'm wondering, have we got the balance right? Does there need to be more focus actually on that aspect of it? What are your thoughts around that?
So I don't think you find a point of disagreement around the importance of continuity of care and the benefits that brings, particularly for those people who are living with long-term conditions who need more regular access. Now, that might not always be continuity of care from a general practitioner. It might also be continuity of care from a physiotherapist, from a pharmacist, or for a member of that multidisciplinary team who is dare I say it, sometimes better equipped to support the specific needs of an individual. But I think we do all recognise, and as we move forward with the development of that primary care route map, which goes beyond just general practice, I think we would absolutely want to look at how we can get back to that idea of a named practitioner who's responsible for your care, which would be depending on what it is that you're living with and managing in your life.
So there is that recognition then, would you say, that the importance of GPs having that holistic view of a patient's overall health?
It's important for GPs and indeed those working in primary care more broadly. So I would include the multidisciplinary team and broader pharmacists, etc., to have that view of the whole person, and for people to be really clear about who is the person in the team who's best placed to support them.
So just moving on, the recent programme for government aims to target cardiovascular disease prevention. So I'm just wondering if you can explain how you're expecting this to improve the overall access to general practice.
Yeah, so as you've identified, the programme for government, I identified a specific action around targeting interventions aimed at reducing the impact of cardiovascular disease, and identified 10 million funding with that. I'm looking to my colleagues around the detail. Andrew, do you want to take this one?
Yeah. No, I'm very happy to speak a bit more on this one, Caroline. So we issued terms for general practices to participate in a cardiovascular disease prevention enhanced service a couple of months ago. I'm happy to say that we've got uptake of over 90%. I think we're sitting around the 94% mark at the minute. And what that enhanced service is meant to do is ask practices to engage with their patients between 35 and 60 who might not have come in for those regular checks around cholesterol, around blood pressure, around diabetes, around smoking in the last few years, get them into the practice, do those tests and kind of see where they are, I suppose, in terms of their cardiovascular health. If their cardiovascular health is in a good place, it's that kind of lifestyle consultation and ensuring that they have access to the appropriate resources within the community. If it's not in such a good place, of course, it's about that whether the lifestyle needs to change or maybe even prescribing kind of medication at that point. And we have made provision for 100,000 people annually to benefit from this service. It is one focused on prevention. It is targeted at areas of higher deprivation because just looking at the data, you are, I think, over 240% more likely to die early of a CVD-related illness in your SMD1 than you are the average. So we've done something quite novel with the funding as well in order to ensure that it is targeted at those areas where people are most at risk, I suppose, of developing a cardiovascular condition earlier on in their lives. So this isn't something that's going to pay immediate dividends when it comes to access, but hopefully, keeping people in good health for longer on in their lives, improving the quality of their lives by getting the care that they need in a timely fashion is something that will pay dividends in the long run. And obviously that's a key part of the the service renewal framework, isn't it? It's that kind of community-first, kind of prevention-based approach. But do you want to comment on that at all?
Thanks,
yeah.
Andrew. And just to add to that, I think this enhanced service, as Andrew said, very targeted, clear outcomes, clear funding mechanism, clear tracking to activity, with a very clear role for practices and general practice to play, I think demonstrates a model for delivering other enhanced services using the benefit of evaluation and targeting prevention. So this is, albeit at a large quantum and scale in terms of 10 plus million of funding, 100,000 appointments, as Andrew says, but building on that, using the SRF approach to prevention and early intervention, and using the general practice model in a very clear way to deliver very clear outcomes with a very clear focus on the things that we know are core to the determinants of good health is indicative both of a strategic approach in general practice, but also a strategic approach in wider health and social care that is embedded in the document that the government published yesterday.
Can I just add one further thing as well? Just one further thing I'd like to add, just building on Tim's point there, is that for the first time nationally, we've not done an enhanced service in a while. We're using the escrow system, it's called. It's an IT system developed by Albasoft, a contractor of NSS. And so in order for the practices to get paid, because it's done on an item of service basis, they will need to code their intervention with the patient in a particular way. And what that will do is allow us to get more kind of real-time data on how many people have been seen from the service, what SMID category, what the type of intervention was. So I'm just very mindful of the committee's point around data. The way in which we are doing this enhanced service could potentially provide a model for other enhanced services if that is something that we want to do going forward. And as a kind of corollary, I suppose, improve the the data that we are getting from general practice, because the way in which we're asking for the data to be coded in order for people, in order for contractors to be remunerated.
That's a really interesting prospect, and I've not had a chance to read yesterday's report yet. Just one final question. I'm just wondering, from what you've said already there, are you looking already, or is there an intention in future to look at things like mental health issues or adverse childhood experiences and incorporate those? Is it more about directing it at areas of deprivation where perhaps those are more likely or more common?
I think that, as both Tim and Andrew have described, that this is the first time we've looked at an enhanced service for a while. And I think we've got laid the foundations to have a really strong evidence base for understanding how that works and how that targeting works as well. But that's absolutely a model I think we'd want to look at going forwards, yes.
Can I just
Thanks, Convener.
Just to add something further, Ms Callaghan, as well, just to make the point that through the Primary Care Improvement Plan, through the multidisciplinary team investment, we are investing in 392 kind of mental health workers, you know, kind of working in and supporting general practices as well. So there are other kind of ways and means in which we are increasing the kind of mental health provision and support within general practice. But obviously, yeah, I mean, that is, that is something that we could kind of consider and look at through kind of core general practice and kind of enhanced service investment as well, obviously. Yeah.
Thank you.
Thanks, Stephanie. Much appreciated. I'm now going to turn to Colin Beattie, who's got some questions to put to you. Colin.
Thank you, Convener. I'd like to ask a few questions around the multidisciplinary teams and progress in transferring services to NHS boards, which apparently has not been going so well. The Auditor General's report makes it clear that there are still implementation gaps. There's insufficient data about the value for money and impact of MDTs. Now, what is the impact of not fully implementing MDTs? On the, the ambition there is to reduce GPs' workloads and enable them to focus on the more complex patients and the whole system quality improvement. So what is the impact of this delay?
So I think you've clearly articulated what the intention was around the establishment of the multidisciplinary teams, and we have some local data on the impact and on the the success, if you like, of those multidisciplinary teams. So in Glasgow, they set up a pharmacist-led pain clinic, which reduced GP appointments by 67% compared to the 6 months prior to that, and the pain scores also improved by an average of 33%, so a benefit for the general practitioners, but also, really importantly, a benefit for patients as well. And we have a number of other examples like that, but the work that we've been doing, and I'll come to Tim and Andrew maybe to say a bit more about that, work we've been doing around the primary care phased investment programme has been about really understanding at a much more detailed level what the impact of multidisciplinary teams is and what good looks like. So what are the things that we need to make sure we've got in place across the country in order to ensure that we are getting the full benefit from that £200 million investment in 5,000 members of staff working alongside general practice. So that's a really important part of our understanding how far we've got and how much further we need to go and what the potential is, and understanding things like what makes the difference. And I think a lot of what we've learnt so far would be it's around the importance of teams really working together and trusting each other. Tim?
In 2018, the transformation envisaged by the MDT was both in terms of transferring services out of general practice, and that was a joint agreement between the BMA and the government based on prior academic evidence and based on an understanding of the impact that it would have. But it was also about making sure that some of the risks held by general practice in terms of employment were transferred to health boards. Now, I do accept, and it is clearly within the Audit Scotland report, that the pace of implementation of the MDT across the priority services has not reached full implementation. And the Scottish Government faced a very important choice in 2022. It could have either closed that implementation gap and spent over £150 million recruiting nationally to close that gap, or it could choose prudently to determine how you could achieve an evidence-based implementation of the remainder of elements of the contract to recruit to the needs of a population informed by health and social care partnerships and boards working with local LMCs and partners. So that's what we've chosen to do. And I think the work that his Healthcare Improvement Scotland have done, both in the 4 demonstrator areas and nationally, to try and inform what full implementation would look like, the benefits that Caroline identifies, and then we've now got dedicated resource in my team to translate the results of that phased investment programme into a strategic outline case using Green Book best practice to determine what the next step should be, sitting alongside core investment in general practice. And that is absolutely to target those benefits, to be clear on outcomes, and to know how we can most effectively transfer not just workload, but ensure that outcomes are supported at a practice level.
The Auditor General said in his report that there was insufficient data about the value for money and impact of MDTs, and yet in specific cases you've been able to give me percentages of improvements. Why that seems like it doesn't fit together?
So I think what the Auditor General was highlighting was that at a national level we didn't have that overview, and because it's been important that the development of MDTs is led locally and is based on the needs within a particular locality. That means that we have had a different approach to what's been prioritised for MDTs across Scotland. And so I think it's been, whilst we do have some local evidence from local surveys, the work that we've been doing around the primary care phased improvement plan in 4 very different areas of the country has absolutely been based on gathering that more, I suppose, systematic evidence around what works, so that we can really inform the next development of the MDTs through that.
Can I say something? Okay. Yeah. I just think kind of one point worth mentioning is that the MDT has grown kind of over a very quick time period and over a very turbulent period as well, in terms of that being through the pandemic. So, we went from, kind of 0 in 2018 to about 3,750 people being funded to work through that primary care improvement fund and working as an overall kind of cohort of around 5,000 MDT whole-time equivalent staff. So to do that type of service redesign and have the NHS working in that intimate way with contractors in which they hadn't in the past over 5 years, that's a real kind of phenomenal pace in terms of that whole-time equivalent figure. However, at the same time, and I think partly because we are working through that pandemic period, we need to do that piece of work on, well, what is the actual impact of putting in more investment at this stage to the multidisciplinary team. I mean, you'll all be aware of the very kind of constrained finances within which we're working, and of course for every pound we put in the multidisciplinary team, that's a pound that we couldn't put in core general practice or kind of elsewhere within our health and social care services and that wider public sector landscape. So it's only kind of right, as Tim said, that we take that at pools, if you could call it that, with the phased investment programme, which has been a huge amount of work on the part of his and the sites, the demonstrator sites throughout the last 2 years, to give us that clearer information on what is the impact here. Have we got the prioritisation right? Because of course halfway through that time period, we decided to prioritise very much on the pharmacotherapy, the CTAT, the kind of the nursing support and the vaccinations in order to inform our policy development and our investment going forward. And the business case is currently configured, I suppose, is going to be looking at that kind of that core general practice and MDT in the round. Yeah. how we move things forward.
Now, I would refer you to paragraph 35 of the Auditor General's report, and he makes it clear here that while some local areas have carried out analysis of the impact of MDTs, robust, routinely available information across Scotland on the impact of the rollout of MDTs is lacking. And he goes on to give some more information on that. Do we have data or don't we?
I think the situation as reflected here is, as I was describing to you, that in some areas, and the figures I just quoted you, and there are others I could quote you, so there are areas that have done their own impact assessment. There are other areas where the data is more sketchy and it's more difficult. And because different areas have prioritised different aspects, and there are different demographic factors associated with different areas, then it has been more challenging to get that national picture.
Could I come in additionally, please? So we've tried to make sure HIS, as a priority task for the entire organisation, is supporting not just the phased investment programme, but also a national improvement collaborative. Their work to systematise and improve data to meet that very point in the Auditor General's report is uppermost in our mind. And the Oversight Board, of which Andrew and colleagues are a member of, to try and gather data in a robust way, ensure that it is available and used within the next phase of MDT implementation, and is drawing from that locally available data that Caroline says, but making it academically and more broadly robust, is key to being informed. And I think if you look at the governance of that programme, you look at the tasking to HIS, and you look at the work with academic partners, I think we have a good story to tell, and we are actively working to address the gaps that the Auditor General references.
How are you going to address the lack of transparency and understanding of spending on each of the 6 priority services? What's the plan for addressing that?
So, the report on primary care improvement plans that was published yesterday for the first time and meeting that Audit Scotland recommendation includes data on financial expenditure on each of the services. So that's the 200 million figure, and broken down by service area that Tim was.
So you believe this? I have not had the opportunity to read that, but you believe that this criticism has now been addressed?
Yep.
Okay, I look forward to reading that report.
Okay.
You've had long-term challenges in recruiting enough people into MDTs. Those sites that have taken part in the phased investment programme, have they fully recruited into pharmacotherapy, CTAC services, enough to inform the evaluation?
Yeah, so collectively they have recruited 135 whole-time equivalent further members of staff, which again is a significant achievement within a very short time period, a time period that had to be short, of course, because we're coming up to the end of a parliamentary cycle, and we want the phased investment programme outputs to be ready to inform that dialogue and debate around the next parliament. So,
but are you saying they're fully recruited?
I don't think they fully recruited to the plans that they submitted as part of the phased investment programme. However, I think that in and of itself is learning, that we need to take going forward in terms of.
Can you give some idea in terms of the shortfall in these areas?
Yeah, I'm happy to share with Mr. Beattie the plans and the current place that those sites are at in terms of their recruitment.
Because
yeah.
I don't know whether you're 10 bodies short, 100 bodies short. What does it mean? If you can give that figure to the committee, that would be really helpful.
Yeah. Up to.
Now, moving on to, you gave transitionary funding to all general practices, regardless of access to MDTs. What was the rationale for giving it to every practice, including those that had MDTs? What was the rationale behind that? And then, of course, you stopped it.
So, yeah, very happy to come in on that. So, yeah, you can imagine that there were very long discussions at the time with the profession, with boards, with health and social care partnerships as to how to implement that commitment around transitionary arrangements. I think given that it was so challenging at that time, and again I hasten to add we were working in that kind of pandemic environment, to be able to catalogue each practice's individual kind of benefit, for want of a better word, from the MDT investment. It was felt that a flat payment at the time was the prudent approach, especially given that we still wanted and still want the focus to be on implementation of that MDT. I mean, the other route we could have maybe gone down is some type of item of service payment, but that would have created a significant bureaucracy at that time, would have risked us taking our eyes off the prize, which was that MDT implementation, which is why we agreed with the BMA at the time to that flat payment structure, rather than doing something that might have been a bit more nuanced but would have created a really significant bureaucracy at a time where, I hasten to add, we were still operating in the pandemic environment.
How do you assess the feedback from doctors that, in fact, MDT, in some cases at least, has created more work because of the needs of training and so forth?
Yeah, I mean,
one doctor said that it takes a year before the people coming in actually are properly integrated into general practice.
Do you want to come with that one?
I think one of the key benefits, and I'm not underplaying the need for integration and the need for whole system delivery, but the boards take on responsibility with their organisation and their structures for that training and for elements of assurance. And I think what we've got to look for is a model whereby those board employed staff come with a sense of assured delivery and sit alongside what is delivered within core general practice. So for me, I'd like to focus on what are the structures and processes for the future to ensure that that integration is efficient, timely, and delivered in a way that the benefits that we're trying to track and assure actually are delivered.
Made to us that primary care is very different from secondary care, and that the transition takes time and a different mindset.
I think
so any training done by the NHS boards, how effective is that going to be when they're moving into primary care?
So I think yesterday, when we tried to bring out the SRF, this idea of fixed and firm distinctions between primary and secondary care, I don't think is the future operating model of the NHS. I think the nature of interface care between primary and secondary care, the need to make sure that you're tracking continuity of the person, and the need to make sure that the things that we're focusing on in a preventative space are very much the focus of board chief executives, NES in a training space. So I do accept that, yes, ensuring that you're equipped and able to operate within a primary care or general practice environment takes some time, but I don't necessarily accept that that fixed distinction is both apparent everywhere, nor has to exist going forward.
Have you consulted with the GPs on this? Get their opinion as to the transition and how long it takes, and what the different skills are that you have to develop?
So general practitioners are not just part of the programme board that we have to oversee the overall programme, but are called to the delivery of training, the development of clusters, and absolutely that feedback and that joint working, particularly with the Royal College, on making sure that we understand what is required to integrate the MDT alongside core general practice is absolutely something we want to do and will continue to take feedback on.
Feedback from the doctors, it sounds like you've got a bit of work to do there to understand that transition. I'm sorry, Susan, I think you were wanting to come in.
Yeah, it's just to highlight that the phased investment programme is looking at these kind of differences between general practitioners and MDTs and how they interface. So we will have much more specific evidence from the 4, what we call our demonstrator sites, being generated as part of that programme. I also want to highlight that the interim report from that programme is also due in July. In terms of direct feedback with that evidence-based programme, yes, we have been told that by our colleagues in SGPC, and we do take that very seriously, and we are taking that into consideration in the evidence base we're gathering from the phased investment programme, but also from working very closely with the health and social care partnerships as well, who are not part of that programme, but the evidence base that they are generating.
Okay, I'll move on from MDTs, go back to data and availability of data. Now, you've been putting in place a new GP clinical IT system. However, the supplier's gone into administration. What's the timescales for rolling out the GP clinical IT system by 2026? Is that still valid? What's the situation with the supplier?
So I just need to be a bit careful about what I say around this, given that the situation in terms of the supplier having gone into administration. But NHS, National Services Scotland, are working on our behalf around that whole process. And they are the organisation that are supporting the rollout as well. And we are very keen to try and stick as closely to the original timetables as possible. If anybody wants to.
And you think that's feasible?
I think that will depend on the administration process and how quickly that concludes.
So we don't really have any idea when it will be?
It's sort of out of our hands just at the moment.
What's your backup?
So I don't think this isn't about a backup. We are confident that that process will conclude successfully, but we can't. We don't. If I knew, I don't think it's appropriate to discuss those timetables, given the impact that might have on the process.
Do we have funds at risk on this?
No.
No. Okay. Now, if there's a delay in the rollout of this system, in the plans for creating a primary care data and intelligence platform by March 26, what's the implications of that?
So I think the rollout of a new GPIT system consistently across Scotland will greatly facilitate our ability to access all the data that we need to access. But at the moment, and I think Andrew already described how Albasoft is being used to extract data from GPIT systems across Scotland, and at the moment that situation still exists. So we can still produce data. We have been improving the data that we have produced. I think that the rollout of the new GPIT will just move that on a level.
In order to make material improvements in the quality and availability of data, is there specific support that you consider should be necessary or could be necessary for general practices to consistently collect and record the data that's required? Because historically there's always been slight differences in the way data is collected across the different practices. So how can we tackle that?
Yeah, so the primary, correct me if I get the name of this, but the Primary Care Data Improvement Programme has been working around supporting practices to code things consistently. I think that new IT will help with that as well, just in terms of providing more prompts in terms of the correct way to record things. But yeah, there is always a challenge when you've got multiple areas for inputting data, of making sure that data is inputted on a consistent basis.
Okay, thank you, Commissioner.
Okay, thank you. I've just got two final questions to put to you, Director General. The first one is, and this may have been answered in the Cabinet Secretary's not so much his statement, but the associated paperwork that accompanied his statement that I think Mr Chapman alluded in part to earlier on. And that is, when I look back to the evidence we took from the Auditor General on the 14th of May, he said, and this is reflected in paragraph 42 of the report, but what he said to us on May the 14th was the Scottish Government still needs to clarify its plans for general practice and to set out the actions, timescales and cost to deliver that. So that's very clear what he's asking for there. Do you plan to publish that?
So we, as you recognise, we published the service renewal framework yesterday. I think that very clearly identifies the direction of travel for health and social care services and the real importance of that, of both primary and community care, general practice in amongst that. It also set out our intention to publish the primary care route map, and that will absolutely get down into the detailed actions alongside that.
And did we get yesterday timescales?
We said within a year.
Okay, everything within a year.
No, sorry, the primary care.
Or the next plan about the plan is going to be within a year.
Route map.
The route map is going to be within a year. But what about action? What about the implementation of the terms of the 2018 contract?
That doesn't mean that we're not continuing to take action. That the route map is about sort of the next steps and the next vision, the next objectives for primary care. This is not about us not continuing to take action. We've already, through the operational performance improvement plan, we've already taken actions in primary care. We are collecting the evidence base for the next scale of development for the multidisciplinary teams through the phased investment programme and through the development of a business case. So we continue to take action and we continue to be in dialogue with the BMA around the investment that is needed to deliver all of that.
Yeah, well, I mean, perhaps in the fullness of time you might also be able to pause and reflect on the evidence session that we had before you came in with the BMA and the Royal College of General Practitioners, because they gave a rather different picture about the action that was needed. Can I just ask you one final question, Director General, as well, which is, again, relates to yesterday's announcement, because one of the things that was announced was the merger of National Services Scotland and NHS Education for Scotland. Mergers and reorganisations often deflect organisations from their core purpose. It's emerged this morning in the evidence session that we had before you came in, but also in the evidence session that you've been involved in, that both of those institutions, both of those parts of the delivery of services are actually critical to meeting the aspirations, the ambitions of the 2018 contract. Don't you think that merging those organisations might deflect them from the things that we want them to get on with, including data collection, including making sure GPs are properly and fully employed?
So we have been really clear in the discussions that we had with both boards in the run-up to the publication yesterday that business as usual must continue unaffected. We think there are huge opportunities for both organisations and huge opportunities for a bigger organisation to do more on behalf of the NHS across Scotland. And I think at the point where we are in our development of our approach towards health and social care services, it was really important that we took the opportunity to actually build on the expertise and the capability and the capacity that's in those organisations in a way that will enable a combined organisation to do more. So we will be working very closely with the leadership of those organisations to make sure that there is no taking of the eye off the ball during this process, but that we're also grabbing those opportunities to do more, to go further, to go faster.
And you just described it as creating a bigger organisation. I mean, presumably part of the thinking behind merging two organisations is to rationalise, is to look at whether there is duplication, whether there is a synergy that might lead potentially to fewer people being employed in the organisation or the services being delivered in a different way. Is that part of your thinking? So
absolutely part of our thinking is about whether there are opportunities there to remove any duplication and to rationalise. But actually a big part of our system, of our thinking, is about what that organisation can do on behalf of NHS Scotland that will also lead to efficiencies in other parts of the system. So yes, the efficiencies and being able to deliver services on a once for Scotland basis is absolutely at the heart of our thinking in all of that.
Okay, well, Director General, we must leave it there, but thank you very much for that final answer. Can I thank all of our witnesses this morning for the evidence that you've given us, Andrew Chapman, Tim McDonnell, Susan Gallagher and Director General Caroline Lamb. Can we thank you for availing us with your time and your insight? There are some areas I think that we might want to follow up, and I think you in turn undertook to give us some more information. So we would very much value that as always. So with that, can I move this morning's committee into private session? Thank you.